our next presentation. Post-operation opioid reduction protocol reduces racial disparity of clinical outcomes in children. This will be presented by David Grabsky.
Thank you for the opportunity to present our work. We have nothing to disclose. We previously implemented a multimodal intervention to reduce postoperative opiate use in children at our institution based on IV Tylenol, postoperative pain education seminars, and standardized post-surgical sign-out, the results of which we've previously presented at this conference. The purpose of the current investigation was to determine if a difference in opiate prescribing patterns existed by race in our historical cohort and whether that our intervention itself was effective in reducing any potential racial bias that we noted in our data. Briefly, our investigation included all children under 1 who underwent abdominal surgery in either the NICU or the acute care floor. This totaled about 250 patients. We used a historical and retrospective pre-intervention cohort and a prospective post-intervention treatment group to compare the effect of our intervention on postoperative opiate prescribing patterns, pain scores, and then secondary outcomes, including clinical safety profile. Here we go. Our primary analysis modality reprocess control charts. The figure represents a time series of all children in our investigation. Postoperative morphine equivalents are represented on the y-axis. Time is on the x-axis, beginning in January 2011 through the end of our period, January 2021. Our intervention occurred in January 2016, so that's denoted by the blue vertical line. This figure reestablishes that the intervention itself was successful in reducing postoperative opiate use by over 98% in our study population. This is the main slide of the presentation where I'll spend the majority of the time. This is the exact same data, but now we're presenting it by race. White children are denoted in blue, Black children are in orange, and Hispanic children are represented in gray. Of note, there were not enough Asian children in our study population to include in the time series. Several trends can immediately be seen. First, concentrating on the pre-intervention cohort to the left of the blue vertical line, it is clear that Black children were prescribed significantly higher postoperative opiates than their peers. For numerical comparison, the median postoperative morphine equivalence for Black children was 13 milligrams per kilogram, while for white children it was 2, and for Hispanic children it was 3.5. This is a 6-fold increase for Black children over their white peers. Now concentrating on the post-intervention cohort, this is to the right of the blue vertical line. It is also clear that the intervention successfully reduced postoperative opiate use in all racial groups. Specifically, the median postoperative morphine equivalence in Black children reduced to just above 0 milligrams per kilogram. For white children, it was 0.05 milligrams per kilogram, and for Hispanic children, it was 0.1. These findings in the post-intervention cohort were statistically equivalent. In summary, this data is consistent with the racial disparity specifically highlighted in Black children in our pre-intervention cohort, which was eliminated following our intervention. Important to the main findings is that there were no statistical differences in either the demographic or clinical variables that we analyzed in either the pre-intervention or post-intervention cohort analyzed by race. This table highlights this point with rows representing different demographic variables analyzed by race, again in each cohort. Additionally, though the data is not presented here, the type of surgery performed in each cohort were proportionally equivalent by race. There were also no difference in postoperative pain scores in either racial group in pre-intervention or post-intervention. Lastly, we also analyzed clinical outcomes associated with opiate reduction. This data is total length of stay in days represented on the y-axis. The pre-intervention cohort data is represented in blue. Post-intervention cohort data is represented in orange. The x-axis is total length of stay for each racial category. The median total length of stay for Black children in the pre-intervention cohort was 45 days, while for white children it was 16 days. This is again a statistical difference and represents a racial disparity in the clinical outcomes associated in our pre-intervention cohort. Following our intervention, the total length of stay for Black children was 8 days, which was identical to white children, which was also 8 days. Though I'm not presenting the data here, we also found a racial disparity in our pre-intervention cohort and other secondary outcomes, including length of intubation and TPN usage as well, both of which were eliminated again by a clinical protocol. In conclusion, the data from our investigation is consistent with the racial disparity in opiate prescribing patterns and associated clinical outcomes in our pre-intervention cohort, all of which were eliminated following the implementation of our clinical protocol. I'd like to thank the senior authors of the investigation, Dr. Jeffrey Gander and Dr. Sandra Capagambe, for their insight in the project and overall mentorship. Here's my provided contact information. If anybody is interested in the quality improvement intervention and would like more details about how we implement it, please contact me. Thank you once again, and look forward to questions.
Open for questions? In the meantime, let me ask you, so what jumped out at me was that 45-day length of stay in those children. Are you attributing that solely to the opioid use, or were there other components to your protocol?
It's such a large difference, and I understand the heart of your question. Thank you for it. Despite analyzing this data in every way I know how, we have not been able to demonstrate that there was another difference. There was no other NICU-based protocols that were being implemented at the same time that could account for the change that we saw over this study period. So it's hard to say that it was the only thing that changed, but at least discussion with the NICU providers who were on this study, there was no other major investigation or intervention that also occurred.
David Huber, WakeMed Raleigh. Fascinating study. Thank you for looking at this. Do you have any insight in the order sets or how it impacts the pain management in the sense that a lot of times these are PRN orders when the child is in pain and things like that? And is there any guidance on how we can, as providers, be more specific in our ordering such that we mitigate these differences? Thank you.
Thank you for the excellent question. That was a big part of our protocol. Specifically in the NICU, they were using a lot of fentanyl drips, just continuous infusions, and then nurse-managed PRN medications. And a large part of our protocol itself was taking that off and just essentially reducing it. And then if a child was felt to need opiates, they would have to directly ask the provider every time, as opposed to having PRNs that could be delivered as a nurse-managed protocol.
Thank you.